and welcome to the Medi Classes postgraduate lecture series on acquired hypothyroidism. Over the last 2.5 years, we have been working on different modules related to pediatric endocrinology, and the PG lecture series has covered many like growth, calcium, electrolyte, along with thyroid and pubertal disorders. So we are going now towards acquired hypothyroidism. And acquired hypothyroidism is one condition which is quite common from a pediatric perspective and something which has significant implications in terms of short and long terms from different aspects, not just growth, but puberty, but many other issues. It can also be a cause of emergency, as was seen in this case. This was a 12-year-old boy who had presented to us with poor school performance. And at that point of time, he was found to have a low FT4 and a TSH of 9. At that point of time, the treating physician considered that this is a hypothyroidism. It's more likely to be a primary hypothyroidism because TSH is slightly high and started on thyroxine. But within a couple of weeks, the child developed hemodynamic instability and shock. And what really went wrong here was that there was an erroneous assessment in terms of thyroid function. In that, when we remember that whenever the FT4 levels are low, we expect the TSH levels to be very high. If they are not high, this suggests a central hypothyroidism. So this was a central hypothyroidism with associated multiple pituitary hormone deficiency, which was missed and resulted in this abnormalities in terms of treatment. So clearly, this is one condition which is quite common, but often can cause a lot of confusion in that perspective. So this is a rare form of acquired hypothyroidism. We'll be discussing a lot about this in that regards. All of you can go and have a look at our website learning.growsociety.in, which has got multiple sources and resources regarding pediatric endocrinology, our e-learning platform, our courses which are there, along with our fellowship and pediatric endocrinology for postgraduate courses. We run a number of activities every month, including this PG lecture series, grand rounds, and journal clubs. And we have multiple publications ranging from pediatric endocrinology protocol to basic and advanced pediatric endocrinology. And our app provides comprehensive assessment of pediatric endocrine disorders, including thyroid interpreter, which is also available. So today we're going to focus about acquired hypothyroidism. Now, coming on to management, the main management is, of course, thyroxine. The one which is easily available is the T4 medication. There is now some role of T3 in certain scenarios, like if you want to bring down the levels quickly, if there is a consumptive problem in that regards. So LT4, use the same brand, and remember that there is minimal role of T3, no role of weekly preparation. Some people used to use some weekly preparations always, which are required. Also remember that the requirement are higher if the problem is primarily in the thyroid versus the pituitary, and the titration which you have to do in the setting of primary is with TSH. For central, the titration is using FT4. You need to evaluate for autoimmune polyendocrinopathy in primary if there are features. For secondary, MRI and pituitary functions are essential, and target is to keep TSH and FT4 in the normal range. Now remember, if there is cortisol deficiency and you start thyroxine without hydrocortisone, there could be a crisis which is precipitated. The dose that you start is typically 100 microgram per meter square per day. So younger the child, higher the per kilogram dose. So 1 to 3 years, 4 to 6, 3 to 10, 3 to 5, more than 10, 2 to 4 microgram per kg per day. And typical dose is 1.6 microgram per kg per day in adults, which translates into 100 microgram per meter square per day. But do not start with this dose in somebody who has a long-standing hypothyroidism, which is pretty much most children who come to us with acquired hypothyroidism. So subclinical or severe cases start at a lower dose. And remember, it can be interfered using the various medications like calcium or iron, soy protein, light. So always keep it within that particular container, which is considered dark in that regards. You should do levels after 6 to 8 weeks, and then 3 monthly, and then 6 to 12 monthly. Keep target of FT4 in the high normal range, around 18 to 30, and TSH between 0.5 to 2. So if your TSH is high, FT4 is low, increase the dose. If your TSH is high and FT4 is normal in the initial phase, you may continue same. And if both are high, this is an adherence issue in that regards. And of course, if they are normal, nothing to be done. If TSH is low, you need to reduce the dose. After some time, TSH alone will be a good marker for long-term follow-up. There are drugs which can influence. So phenytoin, phenobarbital, if they are being started, the requirement will go up. Calcium and iron, most commonly PPIs, will increase the requirement, and use of drugs like octreotide or growth hormone can increase the metabolism of thyroid, and TSH may also be affected. If you need a very, very high dose in somebody who is having thyroid, then you think of malabsorption. Use of anti-epileptic or adherence becomes important, and always ask about calcium, iron, and proton pump inhibitors. You expect that once you start treatment, and we just had a girl today, although who was very much better in terms of height and weight, but in 1 year, she has gained 8 centimeters, not 7 kgs. But the mother's main complaint is that there is now school performance has gone down. That is because they were adapted to a very low level and they were just studying. Now, once the thyroid becomes better, their mind is open and they are doing many other mischievous activities, and they will gradually settle down. But if you start at a high dose, you may cause worsening of school performance. You may cause benign intracranial hypertension. So start at a gradual dose. Watch for headache, limp. So suddenly in the morning, they complains of pain in the knee or hip, difficulty in walking. This could be a clipped capital femoral epiphysis. This is not the effect of thyroxine. This is the effect of rapid growth. So this happens in growth hormone treatment. This happens in somebody who's just growing. Suddenly they may have this sort of a thing, which may happen. So growth deficit may be there, and maybe consideration for GnRH analog. Remember that a lot of hormones play a role. If you give growth hormone to MPHD, thyroid requirement may go up. If you are giving cortisol, they can also be an effect. So thyroid treatment may cause cortisol deficiency, and estradiol will increase TBG, requiring the dose of T4 to be increased. So these interplay may happen. 13-year-old girl, Dr. Alapan, FT4 was very low, TSH is more than 100. Given thyroxine, comes to you with headache and irritability. So what will you do, and what do you think is the cause?
Probably the child is occupied for a long time looking at the TSH level, and thyroxine has started in a higher dose. So probably you should have started in a lower dose and gradually build up the dose. The cause of the headache and irritability, if it is persistent, probably could be a benign intracranial hypertension in this case. So you should look for a retinal
papilledema. Fundus imaging should be done in that regards. 15-year-old boy with follow-up on hypothyroidism treatment, otherwise was doing fine, but now complains of lethargy and weakness. You ordered the reports, FT4 is high, TSH is high. So Dr. Nimisha, what are you thinking of?
Adherence issue. The test has been done by taking FT4.
So you have taken a lot of tablets, the patient has taken a lot of tablets, that's why FT4 has gone up, but TSH takes time. So again, that the point that you brought out is very important, that if you want to do a test, TSH can be done any time of the day, but FT4 should be done only before the tablet is taken. Otherwise, the results would be having an issue from that perspective. So adherence issue may be there. 12-year-old girl, stable on 75, weakness and lethargy. She was started on some medication, after which the TSH has gone up. So which medication do you think could increase the thyroid requirement?
anti-epileptics like penitoin, phenobarbital.
Okay, or iron. So a lot of other drugs can cause that. So calcium, iron, most common is iron. And a lot of people forget. So there has to be a 6-hour gap between the giving of thyroxine and iron to achieve a good outcome. 16-year-old girl on thyroxine 200, TSH is still 100. So what are the things we will think of, Dr. Nimisha?
Malabsorption like celiac disease.
Yes, and
Hemangioma
consumptive. Adherence, most common is adherence. They're not taking a medicine. So in this case, she had anemia and TTG was very high. I've seen many patients whom we identified as celiac because of the high requirement. Dr. Alapan, 4-year-old boy with MPHD on thyroxine 50, started on growth hormone. Suddenly the FT4 is going down. What do you think is happening?
In this case, the hormone obviously increased metabolism of the
Thyroid hormone. So the requirement is going up. This is unmasking or increasing the requirement, which may happen. 16-year-old girl with MPHD on growth hormone, thyroxine and estrogen, complains of lethargy and weakness. FT4 has gone down. She has recently been started on estrogen. So do you think estrogen can do this? So if you have estrogen excess, your TBG will go up and the thyroxine requirement will go up. So in which we like to go, all of you to go and have a look at our website to look at different aspects of pediatric endocrinology, look at the books, the publication, the mobile apps, and we will join again in a couple of months with the subsequent aspect